Hi, my name is Bailey Christian, and today I'm going to be talking about the rate at which women are dying in childbirth and the rates of diseases that pregnant women are suffering from. Throughout this talk, I'm going to be referring to these as maternal mortality and morbidity. Now, what you might be thinking is, wow, isn't maternal mortality extremely rare and outdated for a progressive society like ours? And in part, you'd be right. The last official release of data from the World Factbook shows that the U.S. maternal mortality rate is at 14 per 100,000 live births. I think it's important to point out, however, that other research has shown that these are not comprehensive or accurate statistics, and that the number really ranges between 14.8 and 17.8 women per 100,000 live births. These researchers have been doing research on this maternal mortality rate since the early 2000s, and they project that in 2018, the maternal mortality rate is nearly 20.7 women of 100,000. This graph is an example of an estimated maternal mortality rate in the US from 2000 to 2014. It excludes California and Texas because these are outliers, which I'm going to talk about later on. As you can see, from 2000 to 2014, there's a steady incline, and it reaches about 20.8. But this ratio is still less than 0.01% of the population. So what's the big deal? Well, if we look at this from a holistic perspective, we'll see that the maternal mortality rate is substantially higher than it was 25 years ago, and it directly contradicts the international trend, which I indicate here on this graph. So we can see on this graph that the world's maternal mortality rate per 100,000 live births has decreased steadily since 1990, while the US is on an incline, reaching its highest number yet. The maternal mortality rate is also higher than that reported in 46 other countries, including countries that are considered less developed. This graph shows some of the countries that are on a declining trend while the US continues to climb. Okay, so now you might be thinking, well, that's definitely not great, but I haven't even mentioned the most concerning part. The number of African American women that are suffering from maternal mortality is 3 to 4 times more than white women. This graph shows the United States maternal mortality distributed by race and ethnicity. And you can see that the African American women are suffering at a disproportionate rate. On top of that, 24% of women report experiencing discrimination during the hospital stay for childbirth. That's why I think it's important that we not only talk about the societal trends that are contributing to the maternal mortality and the disease trends in pregnant women, but also the racial and social disparities that are at play and influencing the maternal mortality rate. Although I do want to talk about the racial and social disparities present in maternal health, I also think it's important to talk about the current health trends in American women and the type of care that they're generally receiving. The Center of Disease Control, or the CDC, reports that 60% of pregnancy-related complications are preventable. Most likely what this estimate is referring to is the rise in cesarean sections, or C-sections as we know it, and the rise in chronic diseases for reproductive age women. A recent New York Times article notes that 1 in 3 American mothers delivers her baby via C-section, a number that has risen more than 500% since the 1970s. This raises questions about whether these procedures are necessary or are influenced by our cultural understanding of birth. The World Health Organization, or WHO, reports that C-sections should only be used for medically indicated reasons or emergencies, because although they can often be life-saving, the surgery carries serious risks. The 2 most common pregnancy complications that occur are obstetric hemorrhage, which is dangerous blood loss, and preeclampsia, which is extremely high blood pressure, both of which become more common with C-section surgery. These complications are also more prevalent among obese mothers or those who suffer from chronic diseases. A study published in BMC Public Health Journal in 2018 found that maternal obesity has been consistently reported to increase the risk of a number of pregnancy complications. Okay, so we know that the rising trend in obesity and chronic diseases, coupled with our doctors' tendencies to opt for C-section surgery a little prematurely, is definitely contributing to the rise in maternal mortality. But is anyone doing anything about it? This same article also indicated that in light of their findings, prenatal healthcare providers need to be paying attention and addressing these common complications in order to prevent maternal mortality. But what we find is that there's a relatively widespread lack of proper and affordable prenatal care, especially from women suffering from hypertension or other chronic diseases. In places where women's access to care is limited, pregnancy complications increase significantly. So let's say, for instance, you live in a rural area that lacks Planned Parenthood facilities and the OBGYN office visits are either too far away or too expensive. You have chronic hypertension and have only had one ultrasound since the beginning of your pregnancy. The physician has to perform an emergency C-section when you go into labor, but guess what? There's practically no record of your hypertension and you start to experience extreme blood loss. By this point, it's too late. With more emphasis on prenatal care and wider coverage of prenatal services, mistakes like this don't happen. The lack of attention to prenatal care is compounded by the fact that the United States does not even require hospitals to report medical errors for national consensus. So there is no accurate form of data collection on the number of pregnancy-related deaths that occur in any given year. Ina Mae Gaskin, an expert author in childbirth and founder of the Farm Midwifery Center, points out that any officially reported ratio was a substantial underestimate because there are so many errors in what classifies maternal mortality in the system. Her findings led her to conclude that not only do we have a comparatively high death rate for women from causes directly related to pregnancy or birth, we are almost certainly failing to gather most of the data. So now we will look at two states, California and Texas, that are on opposite ends of the spectrum in terms of the current maternal mortality rates. The comparison of both states' efforts and their main causes of maternal mortality will hopefully reveal the most effective ways to improve the quality of maternal care. So we've all heard the saying, everything is bigger in Texas. And unfortunately, so is the maternal mortality rate. From 2000 to 2010, the maternal mortality increased from a rate of 17.7 in 2000 to 18.6 in 2010 per 100,000 live births, which is still, for the record, higher than the national average. After 2010, however, the reported rate for Texas doubled within a 2-year period in 2011 and 2012, reaching almost 40 deaths per 100,000 live births. Now, there are a few theories I found in the research that attempted to explain this drastic statistical jump. The first is that the increase was the result of improved maternal death records and changes in the coding of maternal deaths. But put in another way, it seems that no one had really taken the time to collect maternal mortality data accurately. I say this because further evidence shows that the maternal mortality figures from 2012 were based on sloppy data collection and coding, to the point that over half of the pregnancy-related deaths that were reported that year were non-existent and therefore completely inaccurate. Others still correlated the spike to Texas state legislature's decision to cut family planning funding by 2/3 in 2011. The real cause for the drastic increase in Texas's maternal mortality rate is moot compared to what it says about the efforts on a national scale. Studies are finding that there are nationwide data collection problems, leading to many errors on maternal mortality reports and inconsistencies among states' reporting methods. So the federal government has not released an official maternal mortality estimate since 2007. Meanwhile, statewide analyses are showing that the maternal mortality rate is still inarguably higher than it was in the 1990s, which we've already seen. This is all to say that in analyzing Texas's failed reporting methods in that 2-year span, we discover the root of the problem: the overall lack of effort in the field of maternal health and a cultural misunderstanding of the impact maternal mortality and morbidity has on our society. This problem is especially glaring since both prior and updated mortality rates for Texas showed that Black women were still severely disproportionately affected. So even if Texas really is trying to improve women's quality of care and trying to adjust changes in data collection and so forth, it doesn't change the fact that there are several racial disparities at play. Now, let's shed a little light on the subject, figuratively and literally, in moving toward the discussion of the sunny state of California. In seeing the rise of the national maternal mortality rate, California decided to devote time and effort to create the opposite trend. The state initiated a pregnancy-associated maternal board review in 2006 and joined forces with the California Maternal Quality Care Collaborate to investigate the primary causes of maternal death and implement quality improvement solutions throughout the state. These solutions included developing a maternal data center to support and sustain quality improvement initiatives, and in the first 2 years of case reviews, it was revealed that obstetric hemorrhage and preeclampsia were the two most preventable causes of maternal mortality and the two most important drivers of maternal morbidity. In response to this finding, hospitals in California established what was called a hemorrhage protocol, including the use of a hemorrhage cart to aid in a quicker response to blood loss incidents. So while the U.S. maternal mortality has worsened in the 2010s, by 2013, California's rate had been cut in half to a 3-year average of 7 maternal deaths per 100,000 live births. These graphs show the maternal mortality rates for California and Texas from 2000 to 2014. The one on the left is indicating that in around 2003, California made an adjustment in the way that they coded for maternal deaths. And then you can see how there was an initial rise in adjusting, and then as they started to add these protocols in and they initiated that care collaborate, it goes on a constant decline until 2014, where it hits about 15.1. Texas, on the other hand, has a steady incline up until 2010, and then we see the drastic jump between 2011 and 2012 that I talked about before. The drastic differences in maternal care between these two states exist due to the lack of national government regulation. Like I mentioned previously, each state oversees its own medical regulations, death certificates, and medical records, which results in a lack of national consistency when it comes to actually gathering data. Gaskin's article notes that if medical errors are to be prevented in maternity care, one of the essential ingredients of a nation's care system is a nationally mandated and funded way to accurately collect data on the number of pregnancy-related deaths that occur in any given year. Regardless of this national inconsistency, we've seen how small changes like tackling the prevention of maternal morbidities in California can make a huge difference in maternal care. But how do we improve, let alone address, the racial and social disparities that are correlated with poor maternal outcomes and that are often overlooked societally? Several studies have worked beyond the mere statistics in order to gain an understanding of why Black women are 3 to 4 times more likely to die from pregnancy-related causes. Is it racism and discrimination? Is it genetics? Is it these women's mere lack of trust in the healthcare system? So here's the research. A study conducted in 2015 and published in the Obstetric Gynecology Journal analyzed a group of women who delivered at hospitals across the U.S. over a 3-year period. It demonstrated that there are significant differences in the type of maternal morbidities that patients experience depending on their race or ethnicity, and that these differences do not appear to be explained by other patient characteristics like age, BMI, or socioeconomic indicators. They conclude that the prevalence of chronic diseases and maternal morbidity should be viewed in the context of race in order to accurately determine outcomes of differences among races. K.M. Bridges' well-known ethnography, Reproducing Race, conducted research at a women's health clinic in a New York hospital in which they interviewed Black mothers and mothers-to-be about their experiences and interactions with the hospital. Bridges revealed that although the hospital is known for the care of the poor and uninsured people of New York, it has become a site where racial inequalities are emphasized and poor pregnant women's bodies are problematized. Okay, so let's unpack that. The U.S. healthcare system depends on public dollars to deliver care to uninsured and marginalized individuals. The common stereotype surrounding these pregnant colored women is one that projects them as rigging the system or free riding and using up the resources of those who actually pay or are insured. Bridges did not have to go far to hear rude and angry comments from the staff or other patients who often would racially profile these patients and immediately assign judgment and treat them differently. This ultimately affected the level of care these women received, resulting in what Bridges coined medicalization of social problems. This can also be known as care discrimination. A study published in Medcare Journal that focused on negative healthcare experiences in 2015 indicated that 40 to 66% of women felt there was communication problems with their physician during their prenatal period, and that 24% of women perceived discrimination during their hospital stay for childbirth, which I mentioned in the beginning. For women who experienced discrimination or communication problems, there were high associations with both hypertension and diabetes. So whether these women are experiencing social, racial, or gender discrimination, the inadequate prenatal care that women receive is bound to negatively affect maternal outcomes. Women who experience any type of discrimination were twice as likely to not attend their postpartum visit, which is an imperative part of maternity care. It provides an opportunity for the patient and physician to address continuing health problems following the birth and health screen for a chronic disease. Inadequate or judgmental care at any point along the pregnancy timeline can have adverse effects on a woman's mental, emotional, or physical health, which inevitably impacts maternal health outcomes. These studies that went beyond the maternal mortality statistical report are essential for showing the deeply rooted systematic issues that underlie the seemingly rare maternal death incidents. Since the rise in discussion about the maternal mortality rate and its severity in recent literature, there are programs popping up around the country that are following California's footsteps by choosing to prioritize the health of women and mothers-to-be. Recent articles have noted an increasing trend of maternal mortality review committees. These consist of multidisciplinary groups of medical and public health professionals that are working to identify opportunities for prevention or intervention by diving deeper into maternal death cases and examining medical records. Since the 2011-2012 incident in Texas, many states are working to improve their data systems in order to better predict maternal outcomes and identify the key factors that are contributing to maternal mortality. On top of that, Doula Support is growing in popularity due to its correlation with positive birth and maternal outcomes. A doula is basically a baby guru that provides emotional, informational, and physical support to their mother during pregnancy, labor, and immediately after birth. The impact of doulas have been shown to significantly reduce C-section births and shorten durations of labor, as well as provide an overall higher satisfaction for mothers during the birthing process. A New York Times article commented that researchers found that pregnant women who received the continuous support that doulas provide were 39% less likely to have C-sections. But it doesn't end there. Expectant mothers matched with a doula had better birth outcomes than did mothers who gave birth without a doula, including being 2 times less likely to experience a birth complication involving themselves or their babies. The harsh reality is that even the interpartum nurse can't attend to every mother's needs during the birthing process. A qualitative study of doula support and interpartum nurses published in the Journal of Perinatal Education showed that nurses can only spend about 6 to 10% of their time engaged in labor support activities as a result of inevitable barriers such as inadequate staffing. Doula support has the ability to completely alter current maternal mortality trends and create an overall better pregnancy experience for all mothers. The issue lies in the lack of accessibility and affordability of this doula service. I think a good place to start with this issue is to educate the public about the services available to them through physician and patient discourse. If, however, doula support does prove to be a service for the lucky few that can afford it, then I think the solution really lies in the overall improvement in maternal, prenatal, and postpartum care. Aspects of prenatal and postpartum care include timing of the first OBGYN visit, adherence to a prescribed visit schedule, so making sure the mothers are actually coming to the appointments, the setting of care, is it an easy location to get to, the quality of ancillary services, availability, and accessibility. Improving the negative maternal mortality trend extends much further than the moment a woman arrives at the hospital in labor. Rather than assessing pregnancy as an isolated event, we should seek to improve the woman's pregnancy experience prenatally, during birth, and postpartum. Through the collection of more useful and reliable data, there are many factors that contribute to maternal death and that all provide an opportunity for intervention and prevention. Over the course of the semester, I was involved in a research project that sought to understand women's birth experiences from a local standpoint here in Richmond, Virginia. Dr. Jennifer Norris, a professor of medical anthropology, led this study and partnered alongside Nurture RVA. Nurture RVA is a program that provides expecting or new mothers resources for navigating motherhood. We analyzed and coded data from surveys conducted by Nurture RVA that asked open-ended questions to mothers. The survey questions we asked included: what is missing in the RVA community with regard to the pregnancy experience? which members of the RVA community are being left out, and what changes would most improve the pregnancy experience within the RVA community. After coding these surveys, my classmates and I conducted interviews with mothers that attend Nurture RVA regularly to gain further knowledge about women's birth experiences and observe possible differences in experiences among various races, ethnicities, and socioeconomic statuses. Keep in mind, my professor wants to write an ethnography of all the data and interviews that are collected over a 2-year span. So none of our results are conclusive yet. I still think it is important, though, to talk about my experiences in hearing these women's specific birth experiences during the interviews that I personally led. I want to tell 2 anecdotes of the 2 completely different women that I interviewed. Different backgrounds, different living situations, different levels of care, and so on. The first woman I interviewed birthed 5 children. I mention this because the birthing process with the first child was vastly different from the rest when she chose to take the reins on her own pregnancy and her own decisions. This is what she had to say about the first pregnancy. Following this traumatizing experience, the mother decided to take a completely different path with her other pregnancies. She decided to hire a doula. She says, "When I decided to hire a doula, it changed my life in so many ways." She goes on, "It was fabulous. Then after that, I was like, this is clearly something that more people need to know about. So I became a doula and a childbirth educator and started working towards becoming a nurse midwife." So this woman who had such a traumatizing experience the first time, as soon as she hired a doula, she was so passionate about the service that she became one herself. Since she had intended to have a natural birth her first time around, her doula suggested she try an at-home water birth, which she ensured would help with the pain and reduce stress and anxiety. The woman said, "When I got in the water, there was like instant pain relief, like I would say between 70 and 90%. She explains it was a wonderful experience because there was so much support. She said, "The care I received, the postpartum care, was just amazing," referring to her doula experience. Her doula talked to her about guidance after she had the baby, different exercises she could do. She gave her a full regimen. It was a completely different experience, and it was actually one that she wants to remember and was super positive. The other woman I interviewed had a completely different experience. As a single African-American woman, she struggled with the anxiety and fear about what she knew as a nurse about maternal and birth outcomes of African-American women, being that they are statistically more prone to complications and maternal morbidities. She says, "Knowing the statistics for Black women in pregnancy and birth shaped all of my conversations that I had. Personally, it stressed me out thinking about even when you can control for all of the different factors, outcomes for Black women is still poor." Despite this stress, this woman felt extremely well supported and cared for throughout her entire birth experience. She saw the midwives at VCU, and she also had a doula because all of her friends had had doulas and said that she just had to have one. She says, despite the fact that her pregnancy was 23 hours even after she was induced, it was still a beautiful experience. She felt very, very well supported. Her midwife was hanging out with her, distracting her during that time. She had been convinced that she wasn't going to get an epidural, but after 23 hours, as anyone would, she was just in too much pain, and the doula, despite her birth plan, said, "Don't worry about it. We support you. You did such a good job. You should get the epidural." And so they didn't beat her up about it, and she felt super relieved by that. Right after the birth, they were very helpful with breastfeeding, and the whole process was just eased by the fact that her midwife and her doula were there the entire time. After these women shared their stories with us, we asked them, what was your most positive and most negative interaction with healthcare providers during the birth experience? The first woman describes her most positive interaction. She says, definitely the most positive was with my midwife, incredibly kind and passionate. She talks about her negative interaction when she says, it was probably that nurse that rolled her eyes because the doctor was doing all these things that I didn't want her to do and I didn't like, but she gave the appearance of being very kind and cheerful as she was doing them. In a way, maybe that makes it worse. The second woman comments on her most positive interaction. I feel like every single interaction that I had with the midwives, my doula, overall, every interaction was a very positive interaction with everyone. Part of what made my interaction so positive is that I knew going in like what I wanted and working in healthcare, being able to be an advocate for myself and having my doula. She describes her most negative interaction. I won't say that it was negative, but I hate to play like nurse versus doctor, but the doctor who read the ultrasound and came in to discuss it with me, he was very, very matter of fact, which I appreciate, but when you just told me like, your son isn't growing the way we expect him to, it's very scary. I got worked up and there wasn't he just pretty much had like poor bedside manner. And so I didn't really feel emotionally supported there. He was basically saying like, when you meet with the midwives, they'll talk to you about your options. So what we can take from both of these women's experiences when they talked about their negative interactions, both of them involved a doctor or a nurse in the hospital lacking compassion or not giving them the independence to make their own decisions about how they wanted their pregnancy to go. When they both came in with birth plans, they had something that this is how they wanted things, and they didn't feel like the doctors respected that. We then asked these women, is there anything specific you think can be done in our area to improve experiences related to birth and postpartum care? The first woman said, I think improving access to and education about the differences between obstetric care and midwifery care is a big thing because a lot of people just don't know. You don't really need a doctor unless you're, about to die. The second woman says, my midwives were really great about here's a list of places that you can go for childbirth education classes. I would hope that if you didn't have a doula and you weren't seeing a group of midwives, that if you went to a typical OBGYN, they would provide you with those same resources. In terms of resources that are available to people, most of us don't know what's available to us. So both indicated that there needs to be more education of resources and services for mothers-to-be. These interviews further show that a positive impact of doula services on birth outcomes and overall patient satisfaction. It also shows that despite recent efforts of maternal care improvement, patients are still struggling to find quality care. Women's health should be made a priority in the quality of care discourse due to the rise in chronic diseases, the prevalence of social and racial disparities, and the lack of attention that the maternal mortality rate has received, despite the fact that we continue to fall behind other developed countries and even some less developed ones. Doula support, physician-patient relationship improvement, advanced data systems, and emergency prevention efforts during the birth event will all encourage better maternal outcomes and a better overall pregnancy experience for women in the United States. Thank you.